Hey folks, welcome back to the show. This is your host, Ryan Kennedy, and today I am talking about heart health. Heart disease remains the nation's #1 killer, despite this entire war on cholesterol we've been having for decades. And the research is clear that other factors may be playing a larger role in contributing to heart disease than just cholesterol. So on today's episode, I brought on Dr. Court Vreeland, if I can get his name pronunciation correct here, to discuss this research on heart health and the dietary and lifestyle interventions that work to prevent heart disease without the use of medication. So I heard Dr. Court on a webinar presentation he did to a group I'm part of on Functional Medicine University. And this guy is a nationally recognized speaker. He's an author. He's a true expert in the field, super knowledgeable. He has a chiropractic background, but his expertise goes far and wide in the world of natural health. So Dr. Court, welcome to the show, man.
Thanks for having me.
What got you interested in all this stuff, man, as far as the chiropractic field and functional medicine as a whole?
Yeah, so I took over this practice actually from my dad. So he practiced functional medicine before it was functional medicine. And I remember I took a biology course I was actually in high school. And I thought, it was really focused on human physiology and those kinds of things. I thought, this is super interesting. And I'm going to go, I think I want to go into healthcare. I want to go that route. And because of my exposure to my dad's practice, that was the route that I decided to go. And so I've kind of taken it from there. And so my dad and I were in practice together from 2006 to 2011. I took over the practice in 2011 and been at it ever since.
Oh, that's so awesome. That's so awesome. Well, I want to start by having you give people listening in an overview of cholesterol. Like, what is it? Why is the medical field been so focused on cholesterol specifically when it comes to our heart health?
Yeah, so cholesterol, I mean, it's well studied at this point. It's a particular type of lipid, and it's important because we need it for a lot of things. It's essential for life, right? There are genetic conditions in which people don't make enough cholesterol, and those are basically uniformly fatal. So we know it's an important part of kind of our everyday physiology. It's in basically every cell membrane in the body. It helps with membrane fluidity and it helps with structure. It's the precursor of some hormones. It's incorporated into bile. And so it's extremely important. The problem is that sometimes too much of it becomes problematic for some people and creates this problem of ASCVD. And it's, as you mentioned, as we kind of went into this, that's still the #1 killer. And, despite this war, I don't think we're winning it with just medications at this point. Obviously, we're not. And I think there's obviously areas for us to improve.
So what's interesting to me, though, I'm curious if you could break down how cholesterol, these, high and low density lipoproteins, cause the heart disease, like cause that plaque buildup, because I'm seeing all sorts of statistics, and maybe you could speak to this more, that a fairly large percentage of individuals who have a cardiac event have low or low normal cholesterol. They don't all have these lipid numbers that are through the roof when they have a heart attack. So what's going on in that scenario?
I think the best way to look at this is that cholesterol is necessary but not sufficient to cause heart disease.
Okay.
It's going to be part of the equation. However, we do know that even if we get to optimal numbers, we're only actually reducing the risk. There's still about 50% residual risk left over. And that's where we get into other things like inflammation and blood sugar and endothelial dysfunction. So those are important factors for us to consider as well, because we do know that, there's been studies and we look at people who have high cholesterol versus have low cholesterol. And during the study period, we actually don't see significantly increased risk of people with high cholesterol versus low cholesterol. But sometimes the time scales on those studies are problematic, right? If we're looking at the time scale of, say, 5 or 10 years, we're generally looking at older populations. Lots of other things come into play. So necessary, but not sufficient to produce heart disease, I think is a good way to look at that. And I think it's an important step to address, but I don't think I think that also means we need to look at other things in terms of those other factors that we look at in terms of blood sugar and endothelial function and inflammation. I don't think we can just look at one and say one is more important than the other. I think we have to look at all. And I used to be one of those guys that looked at cholesterol, say, okay, well, we don't need to worry about the cholesterol if we address blood sugar and we address inflammation and we're exercising and we address all these other factors. I think if you really look at the data and you dive into it really deeply and you look at studies, you can't deny that cholesterol is part of this. And when we look at the lipoproteins that traffic cholesterol around the body, so we're talking about high density lipoproteins, which you can kind of think of as bringing cholesterol from the periphery back to the liver, or the low density lipoproteins, which traffic cholesterol from the liver out to the periphery. The number of those particles matter. How much is being trafficked matters. And so those are the types of things that we want to look at when we're trying to treat patients naturally with that are concerned about ASCVD.
Yeah, I was under the same kind of philosophy years and years ago of if your metabolic health is in line and your, all other biomarkers, your triglycerides, your A1C, your insulin, all these other things, inflammatory markers were really, top notch, really in a good range, that the high cholesterol, high LDL was not a huge concern. And I know that really was popularized during this whole keto movement, over the last, call it 5 to 10 years, where you had all these people eating ultra high fat diets, lots of saturated fat. Their lipid numbers were going through the roof, but they're like, dude, I'm healthy. It's all good.
Right.
And now it seems like the tide is starting to shift back where pre-keto craze, cholesterol was the devil. And then it was like, oh, cholesterol's fine. It's not even important. And now it's starting to kind of shift back to the in between those two extremes where kind of what you're describing, like it does play a role. It's not the only thing that matters, but it does matter. And so I want to dive into, this is a good foray into some of the top blood markers. And we'll talk about diagnostic testing as well that you like to use. But when it comes to blood markers, I imagine just HDL, LDL, total cholesterol is only the tip of the iceberg of what you like to measure. So what other things do you think people should be really prioritizing on their blood panels?
Yeah, so I think first and foremost, I'll mention one thing with the standard lipid panel. It's not something I order alone very often anymore. However, if one is to get a standard lipid panel, what you want to make sure is that you're getting a direct measurement of the LDL cholesterol instead of what's usually a calculation. The calculations can be off, and so I like to make sure that we get a direct measure. So standard lipid panel is a place to start. I think we want to look at particle number. We can break down cholesterol a couple of ways. So we can look at it as milligrams per deciliter. So that's usually what you'll see on your standard lipid panel. So your LDL cholesterol might be 130 milligrams per deciliter. But what that's measuring is the concentration of cholesterol within the LDL particle. It doesn't tell us how many particles there are. I would have said probably 3 or 4 or 5 years ago that particle size was also really important. And while I still think it's a factor to look at, if you have a lot of particles in general, it doesn't matter how big or how small they are. So sometimes I'll get patients in here and they'll say, well, I did this cholesterol panel and said, I have a high particle number, but they're all the large size. That's still not so great because it turns out that the total number of particles matters a lot. And even if it's all the big stuff, it's still particularly problematic. So I'll do a standard lipid panel. I will look at particle size. I will look at particle number. One of the markers that I think we need to also look at is probably the most important one is apolipoprotein B. So it's shorten it to ApoB. So if we look at the 3 main particles that cause atherosclerosis, we're talking about LDL, low density lipoprotein. We're talking about VLDL, which primarily is a triglyceride rich particle. That is not often checked directly, although it can be. Usually what we do for that one is you just take the triglyceride number and you divide it by 5, and that gives you your VLDL number. So back to our particles. We've got LDL, we've got VLDL, and then we've got lipoprotein little a. And lipoprotein little a is a very potent, probably the most potently purely genetic marker for atherosclerosis. Now, on each one of those particles is a molecule of ApoB. So when we measure ApoB, we're actually capturing in one number the total risk in just one absolute number, as opposed to just the LDL or just the VLDL or just the lipoprotein little a. So those are markers that I think are important from a lipid perspective. The other stuff that I like to look at, take a high sensitivity CRP. That's an inflammatory marker. We're also looking at hemoglobin A1C, so blood sugar control. I like a fasting insulin as well. Sometimes those, the fasting either blood sugar or A1C doesn't reflect the metabolic dysfunction, and we see that the insulin is actually high, and it's kind of keeping everything in check, but it's taking a lot of insulin to do it. That's telling us we're a little behind the eight ball there. And then finally, probably on the basics, I'm looking at also a homocysteine as an inflammatory marker as well.
Excellent. I want to circle back to a few things you mentioned. So particle sizes, very interesting take, because I know a lot of people will say like the small, dense LDL particles tend to be more atherogenic. So if you have, call it normal, or let me first ask, where do you like to see total particle, LDL particle number at? It's like, what's a good ceiling or a good threshold that you think is ideal?
The lab that I use, 900 is the cutoff. Anything above 900, I forget what the actual, I think it's nanomoles per something, but 900 is the cutoff. There is no doubt, I think, that the small particles are more atherogenic. I think most people would agree that they happen to be more atherogenic. It just happens that when you get a lot of large ones, that's problematic too. And so that's kind of where I land on that, where I have shifted to considering the particle number less, and considering particle size less, and looking at total particle number in general as the more of a marker to look at. And really, honestly, I'm very, very focused on ApoB. If that ApoB number is too high, I want to bring it down. And labs are not. There's several labs that I use, and they're not really super congruent on what they say for ApoB as a cutoff. Some labs will say under 100, some say under 90, some say under 80. Some people are like, get it as low as you can. I will tell you that I think the most accurate way to look at that is that, look, if you have a pretty low risk, family history is not high, probably you're relatively young, you do lots of exercise, you do lots of things that are good for you in terms of general health, then under 100 is probably fine. If you have a high risk, high family risk, you've already had an event, you've got some kind of other risk factors, then that ApoB number should probably be under 80 if you can get it there.
If you're seeing lower ApoB, let's say sub 80, but you're seeing high particle numbers, is that something you're concerned about? Because that's something I see, like, for example, the particle sizes, total particles of these LDL numbers. I mean, maybe 5% of people I see come in below the lab reference range that you're describing. It seems universally people are somewhere in the neighborhood of 1,500 plus or minus a few hundred on total particles. And then, you look at like the threshold for the LDL small, and it's like, I don't know, 140, 150, and almost no one. Like, again, maybe a handful of times in the last 100 lab tests I've run, I've seen people actually, and these are like healthy people. I'm not necessarily working with a lot of obese or a lot of metabolically unwell individuals in my practice. So I'm curious, in that scenario, like ApoB comes in at 82 or 78 or somewhere in an acceptable spot, but these particle numbers are very elevated. Is that something you just kind of don't worry too much about?
Yeah, I think ApoB is the most predictive marker. I really do.
Okay.
And so that's the one that I'm relying on most to say, okay, I think we've dialed this in. Yeah.
Got it. Okay, this is great. Now, when it comes to ApoB, I'm curious, we can kind of transition now. What are some of the main interventions, the important key dominoes you start with if someone does come back and their ApoB is 130, 120, and they're maybe a normal body weight? Let's say they're not obese, maybe they have 5 or 10 pounds to lose, but they're metabolically pretty healthy. What do you focus on there?
Yeah, so first thing we do is we look at their dietary intake, right? The things that are going to upregulate is going to be saturated fat is going to upregulate that production. I would say that dietary cholesterol is less concerning, simply because it's harder to absorb that, although there are hyperabsorbers that could be a potential issue there. So that's, again, that has been a shift in my mind over the years as well, because I've said, we told you dietary cholesterol doesn't have much, or doesn't have anything to do with it. I'd say that we have to be pretty nuanced about it. And Some patients, it will make no difference. Some patients, it will make a big difference. So I'm not super focused on cholesterol, but it will be a piece that we look at. We're going to look at their dietary intake. We're going to look at their exercise. And then I want to know, what does their family history look like? Because sometimes we run smack into the genetics, and no matter what we do lifestyle wise, we just have run into their genetic potential. And I'll give you a great example. My wife is a perfect example. I know what her diet looks like. I know what she exercises. Her body fat percentage is low. She does a lot right. Her family, her genetics aren't great. And so that's what we ran into. And in order to get that under control, we had to take some additional steps. And so then we move on to supplementation options.
Can we circle back to the dietary interventions? So you mentioned saturated fat. What do you think of other fats, such as, high omega-6, like linoleic acid, people eating lots of nuts and seeds, or monounsaturated fats? Do you find those need to be limited as well?
So this is very interesting. So I find that the best substitute is going to be like the oleic acid, so the olive oil piece.
Yep.
I find that this is based on the Minnesota coronary experiment, Sydney diet heart study. These are older studies. These were controlled feeding studies that were done in the late 60s into the 70s. And basically, to summarize, is what they found was that they took these two populations, which they could control their diet. They were institutionalized individuals. And they took one population and they cut out the saturated fat and they replaced it with basically vegetable oil. The other group was the control. They just continued doing what they were doing. The group that had the saturated fat taken out, they saw their cholesterol plummet. It definitely went down. So there was that definite observation there. However, at the end of the study period, their risk was as high, if not higher, for coronary heart events, heart disease, as the group that basically served as the control. And that was confusing at the time because everybody thought, well, if we just cut this saturated fat out and we put it in these vegetable oils, we should do fine. So it seems that removing saturated fat does bring down your cholesterol. It's what do you replace it with that matters. And so my recommendation is not high vegetable oil intake necessarily, right? Because we could do all kinds of things, and you could fry your food in vegetable oil, and you could do all kinds of negative things that are going to have bad outcomes. So my recommendation is we lower the saturated fat. I'm a big proponent of high protein, right? I think that's important for muscle maintenance and to slow muscle atrophy as we age and all those things. I always recommend lots of fruits and vegetables. I think that's super important. There's the aspect of fiber and binding up cholesterol that's brought back to the liver for processing, so that you don't reabsorb that. So I think that's important. A low glycemic diet I think is obviously very important. You can't cut out the saturated fat and add in a bunch of processed sugar. That's not going to do us any favors either. So high vegetable, high fruit, high protein, probably lower on the saturated fat, although not zero saturated fat. I think that's the kind of the optimal combination. And if you look at the Mediterranean style diet, that one seems to be the most well studied. It seems to have the most favorable outcomes, and that's pretty much what we're talking about here in terms of being able to shift someone's diet.
Makes sense. Back to some of the diagnostic testing. So beyond blood work, I have a lot of people going in doing these artery scans. What are your thoughts on those, or any other diagnostics you like to use besides standard blood work?
Yeah, so there's two scans really that you can get that matter. So you can get a coronary artery calcium scan, and that'll give you a score, right? And they've got these grades. This is mild, and anything above, I think the number is 400 is considered severe, right? That is, I'd say, better than nothing. The problem is that's picking up just calcified plaques. So these are plaques that are stable, essentially. It does mean that there's been some level of atherosclerotic development, right? Because we see these stable plaques. The problem is it doesn't catch the unstable plaques, which are the ones that haven't been calcified yet. And so that you need like a CT angiogram. Those are a little harder to get, but they can be done. And they do give us a window into what's going on. The ones that are easy to do and the ones that I see by far the most would be those CAC scores, right? The calcium artery calcification scores. And I think they're interesting. I don't I don't recommend them a lot unless someone's really adamant. My cholesterol's high. I don't want to do anything. I don't want to take anything for it. I don't want to do a medication. I don't even want to do a supplement. Then I'm going to say, okay, let's get a score on you and see if there's anything going on. If they come back with a score of 0, I can't really say you should actually make a change here. It seems like what you're doing is working, and there's some data to suggest that not everybody with high cholesterol has a high calcium artery score. That's well. There's a study I think was published in the Journal of the American Medical Association a year or two ago, and they found that even if you had high cholesterol, if your calcium score was low, your risk was no greater than someone who had very low cholesterol. So it's not necessarily the concentration of the cholesterol within the particle. It's what happens when it gets trafficked around the body. So yeah, so we're kind of using that sometimes for patients that may want to not do anything, but it's ultimately, I'm going to usually tell people it's probably best to do something about this rather than just kind of let it go, regardless of what the calcium artery score says.
Yeah. No, that's great. That's great. I've been using a test called a carotid intima media scan. Are you familiar with these?
Yeah, I haven't seen a lot of those, but I have seen the thickness of the intima there can
Yeah,
get.
it's also assessing plaque buildup and the actual measurement of the degree of inflammation in the arterial wall,
Okay.
size of the plaque. It's pretty, it's kind of in between what you're describing. It's not as much it's not any radiation, it's an ultrasound, so you don't have the downsides of the CT route, but you also get a lot more comprehensive data than just the coronary calcium score or scan. So I find it to be, and it's very affordable. I mean, these tests I think are a couple $100 for most clinics that offer them. So it's kind of like a nice in between. I could send you more info on that. I use a company called Cardio Risk Laboratories,
Yeah,
and
I'd be interested in that.
yeah, it seems like a pretty good way to assess someone's risk. It's not quite as comprehensive as the CT scan version, but it also is, yeah, a nice middle ground from what I've
Yeah,
seen.
something that's clinically applicable, that's not super expensive, and can be done pretty easily.
Precisely, precisely. So that's great. That's great. Now, when it comes to some of the genetic predispositions, like the lipo little a, as well as just having high lipids, even when someone's following, low saturated fat, really healthy dietary practices, good lifestyle. Uh, do you find it's still pretty important to lower their lipids? Like I have a number of people I work with where the high lipid count, the high LDL, the high ApoB does run in their family. The parents have it. It's pretty common, but they don't have a lot of history of heart attacks or death from heart disease, right? Even though they're, high lipids across the board. What are your thoughts on that? Is that just a case by case basis? It really just
Yeah,
highly varies.
I think it comes down to risk tolerance for the patient, and
Yeah.
that's the conversation that I have with patients. They come in and let's say they've got middle of the run cholesterol. It's not super high, it's not super low. The conversation I will have with patients is, do you want to do something about this? What is your risk tolerance? I think that by doing X, Y, and Z, we can lower your risk. If we're talking about your 10-year risk or your risk in 20 years, if you have a low risk in terms of family history, sometimes people will say, I'm not particularly worried about it. And I say, okay, that's kind of where you fall on this. And the same thing goes for the patients with the very high lipids. It's all about risk, right? So again, I always go back to that study. There are people with very high, like familial cholesterol, hypercholesterolemia level of LDL, 190, 200, 200 and above.
Yep.
And, they've got a calcium score of 0. So it's possible. It's also possible to smoke for 40 years and not get lung cancer. It does happen,
Yeah.
right?
Yeah. Yeah.
So
No.
it's all about risk tolerance. And my thing is that I think I can safely reduce your risk. And here's how we would do it. If you would like to choose that, let's work on it. And if you don't, then the risk and you're choosing to accept that risk. I mean, there's no guarantee that you're going to have a heart attack. There's no guarantee that you won't. But I think we reduce your risks by treating you with X, Y, or Z.
Makes sense. I want to switch gears into supplementation. So when someone does have moderately high risk based on their levels, and they don't want to, they personally just decide, I don't want to be on any pharmaceutical interventions. What supplements do you find will complement some of the dietary and lifestyle changes that you're making for them?
Okay. So the big ones, the main three that I use are going to be red yeast rice, which is a natural statin, right? It works just the same way as a statin does. Niacin, and then plant sterols. Um, I put them in that order because that's the order that I find in terms of effectiveness. Red yeast rice is very effective. The one potential downside is that it may have similar side effects to the pharmaceuticals out there. Now, up until this is probably 4 or 6 weeks ago, I would have told you I've never seen anybody come back with any kind of issue taking red yeast rice. No muscle soreness, no muscle pain, none of that. And then it happened. And I had a patient that I've been treating for a long time. We decided we are going to manage some of her lipids for her. And after about, I think it was about a month on the red yeast rice, she just developed muscle pain. And she stopped the red yeast rice. It all went away within 4 to 7 days. I mean, she's just not a good candidate. She had a family history of statin intolerance, but she was willing to try. And so that just wasn't for her. Outside of that, I've never really seen any kind of issues with that. Niacin, I use that if the lipoprotein little a is high. It's the only thing that's really going to make a dent in that and bring that down. The downside of niacin is you have to use nicotinic acid, and it gives you that flush, the niacin flush. Some people find that very uncomfortable. Some people don't mind it at all. Some people don't even notice that it's happening, right? So that's the downside of that. And then the plant sterols, they are designed to bind cholesterol in the gastrointestinal tract, not the stuff that you're eating, but the stuff that the HDL particles bring back to the liver and the liver puts in the digestive tract to get rid of it. By binding that up, we don't reabsorb it. And that ultimately means that our cholesterol is going to drop. The downside on that is that I don't find huge improvements with that alone. I usually use it as an adjunct if I'm going to use it. The other downside is that, most of the products that I find that are helpful, in order to get enough, the pill load is pretty high. It's like, sometimes 8 capsules, 8 pills a day, right? So that kind of turns some people off.
Sure.
I will say that the niacin and the red yeast rice, it's very important that people take it at bedtime. We make most of our cholesterol at night. And so we want to interfere with that process. And so people will be let's say, oh, I see this routinely. People will come in, will follow up after 3 months, and I look at their lipid profile, and it's not that different. Like, what happened? So this actually happened on, I think Monday or Tuesday. Patient of mine came in. It's been 6 months since his labs were done, and I looked at him. I was like, gosh, they're certainly not better. If anything, they're a little worse. And so I thought in my head, he's either a non-responder, and we're gonna have to make a whole shift here, or he just wasn't taking this as directed, and this is what resulted. And so he came in, and I said, okay, so what happened? Were you taking this or not? And he said, nah, sometimes I forget at night, so I'll take one in the morning. I was like, okay, there we go. Really take these 3 capsules right before bed every night. It's the red yeast rice. And then we'll recheck in 3 months. And he was like, okay, I'll rededicate myself. So sometimes those things happen. Omega-3s, there's some data that they might increase LDL. I don't see that a lot. Clinically, I don't see that a lot. I do use fish oil on lots of people for lots of things. It is particularly good if people have high triglycerides. Works very, very well if the triglycerides are high. So that's an avenue that I'll use when the triglycerides are high. But I don't see that they make a huge difference with the cholesterol.
Very interesting. Now, with the red yeast rice, what's the dosing range you'll typically have people on?
I'll start almost everybody on 2,400 milligrams before bed. And
Okay.
I will go as high as 3,600. I've not needed to go above that. And maybe we would see more benefit above that, but I just haven't seen that be really necessary.
Makes sense. And when it comes to the statin drugs, do you use those as well in your practice?
I can't prescribe them, but there are times that I will recommend patients say, look, I've done as much as we can do, right? We've changed your diet. You're exercising. We did the red yeast rice. We added in an adjunct of, say, plant sterols or niacin, and we can only get you this low. You would benefit by going lower. And that is sometimes a place where I will say, I think it's time to think about a pharmaceutical. And for me, that's a huge switch, right? Again, I'm the guy, I mean, I have a presentation that I did. This is probably 5+ years ago now, but the title of the presentation was Heart Health, Cholesterol is not the problem, right? So for me to kind of make this switch, I mean, after I looked at all the data, I had to kind of sit down and say, look, I mean, maybe getting this lower is better. And if that requires a pharmaceutical, then maybe we need to accept that. And maybe we need to accept that the risks associated with something like a statin may not be as great as having a really high cholesterol level. So again, we're managing the risk profile. If the risk is, I'm going to make these numbers up, but if the lifetime risk of you having this high cholesterol is 20%, and the risk of you getting a side effect from the statin is 3%, I think we trade those things off, especially considering sometimes the side effects are completely reversible. You have that heart attack, you have that widowmaker, you get tissue death in your heart. That's not reversible.
Certainly, man. That's a good way to position the perspective. With the statin side effects, I'm familiar with like the muscle pain and muscle cramps and other types of things. It seems like some of that can be offset with CoQ10 or GG, things that help to replenish what CoQ10 might be becoming depleted with the statins. But the other concerning side effects people, I think, I think is cause for concern is some of the memory loss and, increased risk for dementia, which, people might have a family history of that. What are your thoughts on those potential issues?
Yeah, I think if you look at this and the interventional and epidemiological trials seem to suggest people that are on statins actually have lower rates of dementia. That may be just a phenomenon of what's good for the heart is good for the brain, right? If we can make sure that the conduits that are delivering fuel are really working well, more fuel to the brain, less incidence of dementia. Now, there is some concern, however, that there might be a unique effect of the statin not necessarily lower cholesterol in the brain. So the pools of cholesterol in our body are at least the ones related to our brain and what we're measuring on a blood test are separate, right? So when we take a statin, we're not necessarily lowering cholesterol in our brain, right? We're actually probably only lowering what we're actually measuring in the blood. However, there seems to be some concern that if a statin is a lipophilic or hydrophobic, so it's a statin that can cross the blood-brain barrier, that we may see changes in a particular subtype of it's not a subtype of cholesterol. It's actually part of the cholesterol synthesis. It's called desmosterol. And if that level is lower in the brain, we see maybe that there's an increased risk. And so the thought process is maybe people would be better off with a statin that does not cross the blood-brain barrier than one that does. Because then we're keeping cholesterol compartments completely separate, right? We're not affecting cholesterol in the brain in any way. And so that's a possibility. I think if the risk is there, I don't know, it's probably pretty low. And I think the risk of developing significant atherosclerosis where you've got a calcium score of 450 and you can't, you've got chronic hypoperfusion of your brain over the course of 10, 20, 30 years, that risk is pretty significant in terms of dementia, for sure.
Got it. Yeah, interesting. Way to look at this. With do you think about any other ways of managing high lipids? So we talked about the diet and lifestyle, supplementation, statins. Are you you have a strong opinion on like these PCSK9 inhibitors or?
I think they're interesting. I mean, as far as I can tell from the statistics, there doesn't seem to be much side effect. I will tell you that I've only seen a handful of patients that can get them at this point. They have to be, it's driven largely by managed care and insurance, and they're still expensive. And if you haven't failed traditional statin therapy, meaning either you took it and you were a non-responder, or you took it and the side effects were so horrendous that you couldn't take it any longer, it's going to be more difficult to get a PCSK9 inhibitor. I think if you and I sit down and have this conversation in 20 years, that's going to be the first line. nobody, statins may be an adjunct to people where the PCSK9 inhibitors don't bring it down low enough. But I think that's a place where we're going to see that. I think that's where it's going. Those PCSK9 inhibitors are going to continue to advance, and then they're just going to be more common. But they're hard to get at this point. But I just think that we can do most of it with diet and or supplementation. I mean, that's where I've been really successful, is just helping people without the use of medications. I'm not against the use of medications, and I think that they should be an option for people if we can't really manage it the other ways. But I think when people go into their primary care doctor and they go into their into the cardiologist and they say, well, if you don't want to do this with medication, you got to do this with diet and exercise, and that's where it's left, right? That's super difficult. That's like, the electrician comes into your house and he's like, yeah, you just got to fix all these wires over here.
Yeah.
See you later. And he does, there's no more education. There's no more help. There's not. Well, I know that needs to be fixed, but how do I do it? Right. And so that's where my practice comes in, and we tell people how to, we guide them. We track biomarkers that tell us that this is getting better or that's getting better. And we help them with their exercise plans. And I think that's an important part that just gets missed. And then once all that stuff has been done, then if we're not where we need to be from a cholesterol standpoint, then we might consider a medication. But that is really infrequent in my practice. I just don't see it that often.
Mm-hmm. No, well said, man. It's the detailed guidance that makes all the difference for people making these changes. Switching gears, what are your thoughts on the long-term impact of stimulants like caffeine? Someone's a big coffee drinker, on heart health.
I used to have a kind of a harder take on this, but I just think that within, kind of, I wouldn't even call it excessive consumption, but within a relatively wide spectrum of consumption, I just don't see that there's a huge negative impact. Especially, there seems to be some relative health benefit to caffeine itself. There definitely seems to be a health benefit to coffee because of the antioxidant capacity that it has. I am not overly concerned about the effect of caffeine. Now, somebody has extremely high blood pressure, right? And it's just not being managed. Maybe caffeine is not the place for them. If they've got, an anxiety disorder and it drives their anxiety and it drives their blood pressure, maybe not the greatest place for them to go. But I'm not sure that's a massive problem that we need to worry about.
People are going to love hearing that.
Usually they do.
Yeah, which I agree with your stance on it. As someone that enjoys some caffeine myself. But yeah, I mean, this has been super helpful, Dr. Court. Really awesome information. Where can people go to learn more about your work?
Yeah, probably the best place. I mean, I'm on Instagram. It's at Vreeland Clinic, and they can find me there. I post stuff there all the time. We're on Facebook. It's the Vreeland Clinic on Facebook, but that's primarily where I am. And I lecture for Biotics Research. So if you're familiar with that company, they have a lot of my stuff on their website from webinars. And then, of course, Functional Medicine University. I lecture for them fairly frequently as well.
Awesome. Well, thanks for taking the time and sharing all this great info, man.
Excellent. Thank you for having me.
Thank you so much for tuning into today's episode. If you found it helpful, please share it along to anyone else you believe it can serve. You can submit your own question to be answered on the show by going to ryankennedyhealth.com/podcast. Be sure to subscribe and leave a review for the show. Your feedback helps to support me on my mission to positively impact as many people as possible with this information. Please note, the information depicted in this episode is purely for informational purposes only. Please consult your healthcare professional before making any changes to your lifestyle or routine.